My name is Mitchell Wharton. I'm the president-elect for ANAC, and I'd like to welcome you to the final closing plenary for this afternoon. But before I do so, I have a couple of quick announcements for you. So I just want to remind everyone that attendees are eligible for up to 18 hours of nursing continuing professional development, or CNEs, and the link is in the app, and will also be sent to you via email after the conference. Also, if you're interested in joining an ANAC committee, information about each of the committees is available on our website, including the contact information for the staff to talk with folks, or you can reach out to any of the members of our nominating committee. Alrighty, with that, I'd like to introduce you to Dr. Jason Farley, who will be leading this session and update on the monkeypox outbreak of 2022. Dr. Farley?
Good afternoon, everyone. Thank you for hanging in with us to the very end. It's wonderful. Don't forget our celebration of life is immediately following this particular session. And those of you who might be new attendees, it's a wonderful time of reflection and remembrance. I have the wonderful opportunity to introduce a panel of true experts when we talk about the monkeypox response, both at a state, federal, as well as clinical level. And I'm really excited to introduce this wonderful panel. I'm going to start here with Dr. Kwong, who needs no introduction to this audience, but Dr. Kwong is a professor at Rutgers University in Newark, New Jersey, and is a practicing clinician at Gotham Medical Group in New York City. He's, of course, the past president of the Association of Nurses in AIDS Care and a co-chair of the Infectious Disease HIV Specialty Community for the American Academy of Nurse Practitioners, an honor that I get to share with him. Dr. Stephan Perez is a lieutenant commander in the U.S. Public Health Service and a nurse epidemiologist in the Detection and Response Branch in the Division of HIV Prevention at the Centers for Disease Control and Prevention. In this capacity, he works with state and local jurisdiction to provide support and technical assistance for detecting and responding to HIV clusters and outbreaks. Prior to this work, he was an epidemiologic intelligence service officer at the New Jersey Department of Health. In support of the CDC's multinational monkeypox response, he recently served on the policy and partnership team, coordinating efforts between CDC and national clinicians for monkeypox-related initiatives. Finally, Dr. Erin Whitehouse is a nurse epidemiologist in the Division of Global Health and TB at the Centers for Disease Control and Prevention, where she supports PEPFAR implementation globally. After completing her PhD at Johns Hopkins University School of Nursing with me, yay, looking at multimorbidity among patients living with HIV and tuberculosis, she joined CDC as an epidemiologic intelligence officer in the pox virus and rabies branch. There she has provided clinical consultation for suspected pox virus infections, conducted surveillance analysis of monkeypox in the DRC, and worked on several rabies projects domestically and globally. I'd like to welcome her to the stage to kick off this session, and she'll provide us an update on the monkeypox outbreak in 2022. Dr. Whitehouse.
Thank you all so much. Good afternoon. Yeah, when I said, oh, Mom, guess what? I'm going to be in the pox virus and rabies group. And she was like, what? And now everybody's like, ooh. I actually know something relevant related to pox viruses. So yeah, good afternoon. Thank you for being here. I'm excited for this opportunity. And I participated in the monkeypox response in the first sort of 6 weeks on the clinical task force, which was really focused around guidance and distribution of medical countermeasures. And so that was sort of my experience. So we're just going to give a brief overview of sort of the outbreak, and then the best part is the panel discussion and being able to talk and hear from you all. And I just want to take this opportunity. You know, I'm up here talking on behalf of CDC, but public health is all about relationships, and local and state health departments, that's actually where the best part is. And they were really the ones that did the on-the-ground work to respond here. So even with all of this data and with all of this information, I just want us to really remember that, you know, CDC plays a part, but local and state health jurisdictions are absolutely the main players that really helped and supported this response. Yes, and to all of you that are out there with state and local health departments, we'd love to hear from you during the discussions. So just to put us on the same page, monkeypox virus belongs to the orthopox virus genus. It is related to smallpox, which was successfully eradicated in the end of the 1970s. It's also related to Yersinia virus, which is not only used in the current smallpox vaccination, but it's actually used a lot in research, so both in cancer research and HIV vaccine research. So it's a really useful virus for a lot of different things. And then it's also very famous for being related to cowpox virus, which was the first vaccine. Edward Jenner, back in the end of the 1700s, figured out that if we inoculate somebody with cowpox virus, which is more mild than smallpox, that we can save their life from smallpox. Although Jeopardy, fun fact for you, there is a lot of controversy in the pox virus world because we think it might actually have been horsepox and not cowpox. As you can tell from the names, pox viruses are generally named from the animal with which they're found, which is why monkeypox is called monkeypox, because it was first discovered in research monkeys in 1958. And then it was really primarily talked about in humans in the 1970s and 1980s when public health professionals were looking for smallpox cases, and they came upon patients who had smallpox-like lesions, particularly in the Democratic Republic of Congo, and that was sort of where monkeypox was first really described. And the ecology around monkeypox is fascinating because it is generally thought of to be in small African mammals, but the particular reservoir is unknown. So that's all your fun facts about monkeypox. It generally was rare and mostly in West and Central Africa, particularly in Nigeria and Democratic Republic of Congo, until May of 2022, when it started rapidly spreading. And the WHO did declare it as a public health emergency in July, and then the US followed in August. And just as a reminder, I'm sure many of you already know this, but it's primarily transmitted, person to person because of infectious lesions. But it can be transmitted via items like clothing or linens. It can also be transmitted from pregnant women to their fetus. And people are infectious once symptoms begin until those lesions are completely scabbed and those scabs fall off. And these are some pictures of classic lesions, both from endemic countries, and then actually there was an outbreak in the US in 2003 because of prairie dogs that had ridden along with Gambian pouched rats and got monkeypox and then infected about 47 people across 6 jurisdictions in the Midwest. So this is not actually the first outbreak of monkeypox, but is certainly a different kind. And you can see that the lesions, particularly in endemic countries, are much more widespread across the body, and there's generally a very significant febrile prodrome flu-like symptoms. But if we look at the 2022 outbreak, we've seen a really different case presentation, which we'll get into a little bit later, with primarily lesions in the anogenital area and much, much less of a febrile prodrome. And so people are not having fevers, they're just presenting with rash as their first onset symptom. And the exciting thing is, because of kind of long-term bioterrorism work, we actually had a vaccine pronounced in many different ways, and I call it Jynneos, but it's like, I don't even know. I think that's not correct. But the great thing was, prior to 2018, the vaccine that we had was a live replicating virus that caused an infection on your arm. And some of you probably have scars from your smallpox vaccines. But in 2018, the FDA approved a non-replicating Yersinia virus that's a sub-Q or now an ID injection. And that was really exciting because people living with HIV and other folks who are immunocompromised could not receive ACAM. And then also, because of bioterrorism research about smallpox, we have treatments that can be used for monkeypox. None of these are licensed for monkeypox. They were all, and particularly tecovirimat is the primary treatment. And this was licensed based on animal studies, pretty much exclusively, and then it was given to humans who were healthy. But prior to this outbreak in the US, had been given to one person for monkeypox with really little effect. And I actually, when I was an EIS officer, I gave it to somebody who was a needle stick of Yersinia virus and ended up with a very nasty necrotic infection. And again, it was not very clear that it had a lot of effect. And so one of the challenges, is when we had this large outbreak of really balancing access to medication that we think should be effective based on animal studies, while making sure that we had enough information to think about, the safety of this. Are there side effects that we don't know about? And what was it, Thursday evening, CDC just released a health alert network around tecovirimat resistance, and that was something that we were aware of that could potentially happen. And there were 2 cases, I think, of severe monkeypox that have now demonstrated TPOXX resistance. And this isn't unexpected, but it just points again to this challenge of, access and making sure that people that needed TPOXX, and even figuring out who those people were that would most benefit from it, with kind of the stewardship around making sure that we're using this in an effective and safe way. And then there are the other drugs that can be used, and in general in this outbreak they've been used in the more severe cases, including Vicinia immunoglobulin, cidofovir, and an oral kind of pre-version of cidofovir called brincidofovir that was just recently, in the last couple weeks, available through the Strategic National Stockpile through an FDA investigational new drug protocol. All right, so we'll just briefly go through some broad epi. There are about 80,000 cases worldwide that have occurred since May. You can see the vast majority are in non-endemic countries, and the US is still up there with the highest case count. In terms of the worldwide trends, it really rapidly accelerated until about mid-August and then has been steadily declining, although the most cases now are sort of in the Americas as opposed to Europe. In terms of the US, we had our first case at the end of May. This outbreak has been primarily among men who have sex with men, and the initial spread was really associated with international travel. But by mid-August, we had over 10,000 cases. And we've had cases in women, children, some pregnant women, and others have been reported. This is our trend, and again, it's very similar to the global trend, where our peak was sort of the beginning of August, and then we've seen a steady decline. And that decline has been in part because of vaccination, which has been wonderful, and also behavior change. So there was a study that was published, I think in August, don't quote me on that, but just showing that men who have sex with men were reducing the number of sort of one-time encounters, and that was a really important piece of trying to prevent ongoing transmission. We have almost 29,000, I won't say 30,000, almost 30,000. We've had 29,000 cases. You can see that California and New York, Texas, Florida, and unfortunately the state where I'm from, Georgia, are sort of topping the list. And those have been the states and the jurisdictions that have sort of been consistent. This is looking at monkeypox cases by age and gender. As you can see in the dark blue, it is overwhelmingly men, and generally between 20 and 40 years of age. But there have been pediatric cases for sure. If we look at the trends by race and ethnicity, this starts to point to some of the challenges and the disparities. So when you look at the beginning of the outbreak, it was really predominantly among white men. And then as the outbreak has continued, it's really much more evenly split between non-Hispanic Black men, Hispanic men, and white men. And unfortunately, those are also the folks who are who are disproportionately affected by the vaccine inequities, as we'll get to. Here are a few studies just about some demographic and clinical characteristics. I won't dwell on this, but the biggest takeaway is there's a lot of people who are living with HIV, and there's a lot of people who are either having concurrent STIs or have had a history of STIs, and then the multiple partners are all sort of risk factors related to monkeypox. And this is some data from the US that again just shows that 60% had either HIV or an STI. And the biggest takeaway from this, which you all already know, is like we need to do comprehensive care, and we now need to add monkeypox to sort of that list of comprehensive care as we're thinking about people who are at risk. and testing for STIs, testing for HIV, and thinking about monkeypox when you have a patient that has an anogenital lesion and related high-risk behaviors. I'm like trying to the math is difficult on the timeline. One thing that has come up that I think is really important, particularly for those of you that are providers, is unfortunately, in part because of vaccine inequities, what we're really starting to see is severe infections, and this is often among people who have advanced HIV because they have undiagnosed HIV. And so CDC does a lot of clinical consultations, particularly on severe infections. And this is some demographics from a recent MMWR showing that the vast majority were male, almost 3/4 were Black or African American, almost 1/4 were experiencing homelessness. And then there were, among the 47 patients living with HIV, almost 1/4 had a CD4 less than 50, and only 9% were on ART. And these patients are having, many more lesions. They're having necrosis, sepsis. Monkeypox can invade any organ of the body, and 30% of this 57 required ICU care. So unfortunately, we're really hitting a spot where the majority of people are getting vaccinated, but those that have been left behind are really at high risk. And so really briefly, one of the things I just want to highlight is the Laboratory Response Network, because again, CDC and state and local partners have been working on sort of emergency preparedness, and there's lots of room for improvement, but we were really able to quickly detect monkeypox because there's a whole laboratory network that does regular preparedness exercises to be ready for this type of situation. And testing capacity was really able to be quickly accelerated, which was exciting. I know that access to testing depends on much more than the ability of the lab to do it, but that's an important step. This is a slide that I won't dwell on for a long time, and it's a bit old, but I think it just shows, the ways that we tried to help with this response in terms of laboratory testing, really trying to modify the vaccine strategy as we had more vaccine available. So moving from a post-exposure for those who were known exposed to realizing that contacts, what is really challenging when you have people who are reporting anonymous sex and you cannot do contact tracing, to sort of an expanded post-exposure for people who might have been exposed. And now, in part because of the move to intradermal vaccination and the availability of more doses, we're able to move to now a PrEP model where we can really vaccinate people who are at risk. And along with that, we also, we did COCA calls with clinicians. Steph, my colleague, can talk about some of that outreach, but all of these kind of arrows along the way are different outreaches trying to get to clinicians to make them aware of what was happening. And we've administered over 1 million vaccine doses of both first and second doses, and that's really an amazing accomplishment across all levels, and really exciting to see. And we also have been able to repurpose some of the COVID tools such as vSafe. So that is now available for people with monkeypox, which is, again, just a really exciting opportunity to develop something for one thing and then be able to use it for another thing. And also in exciting news is that we really had no idea how JYNNEOS was going to perform with post-exposure because it's never been used in that setting. And this is, some preliminary data. Ongoing work is still being done around vaccine effectiveness, but among people who were eligible for monkeypox vaccination, unvaccinated persons had a 14 greater risk of developing monkeypox than vaccinated people who had only received 1 dose, which is also exciting because this is a 2-dose series, and in theory, you do not have maximal effectiveness until 2 weeks after the second dose, so a total of 6 weeks. So that's really difficult when you're in a post-exposure situation. And so the fact that there was this much of a difference even after 1 dose is exciting and promising. As I mentioned, one of the areas that we really need to grow is an equity and vaccine strategy, and CDC, along with many partners, is really working to try to improve that with a vaccine equity project. And we've already seen some difference. There's still a lot of room to grow, but as you can see here, among Hispanic and Black populations, we have been able to increase their percentage in terms of the number of vaccinated people. which is very great. And then I'll sort of skip this for the sake of time, but this is, we do things, public health is challenging and lots of fun, and we love working with our state and local and other partners. So thank you all so much, and we'll get to the panel.
Well, thank you so much, Erin, for setting the stage and getting us all kind of the background on all the responses the CDC has done. And and also, Stefan and Erin, thank you for your work and your leadership and representing the profession of nursing so ably within the CDC. So, in terms of strategies related to diagnosis, treatment, and harm reduction that you guys have implemented at the CDC, what do you think has been most effective in helping to, number one, get the word out, get the messaging out? And Stefan, this is really, I guess, your area in terms of community engagement. What do you think has helped to, change behavior as well as it has for this particular response?
Yeah, I think that's a great question. And as I start to talk, you all will realize that I am not a pox virus expert by any means. So coming into this work I was coming from the Division of HIV Prevention, which has a wide scope of work across the country. And I think early on in the response, CDC realized that although this was pox virus and we have many wonderful experts, we also needed that community engagement piece that HIV providers, that Division of HIV Prevention has done for many years, particularly because of the population that was being most affected in this outbreak. And so one of the things that we started doing early on was simply engaging community members, engaging LGBTQ+ serving organizations and institutions and organizations that advocate for people living with or who are affected by HIV. We talked with owners of sex on premises facilities, which are clubs, bathhouses, but CDC has to have a term for all of those things.
That's a new one for me,
Yeah.
sex on premises.
It was a new one for me
Okay.
too. I was like, what? Oh, okay.
Can I
got
Google
it.
that?
You sure can. It is, so if you see in our guidance, sex on premises facilities, that's what we're talking about. We did put in parentheses what that actually is for everyone else except for CDC. But we found that it was really important to engage those folks in listening sessions to hear what exactly was on the ground, what are the needs that they're seeing in their communities, because what we know from other responses, and definitely COVID, is that nobody wants the government coming in and telling them exactly what to do and how to do it every time. You have to use trusted messengers in the community to get those messages out, and that is what ultimately will change behavior. And so that's one of the strategies, because one of what many of those listening sessions told us is that a harm reduction approach is really one of the most important pieces. So not necessarily stopping behavior, but how to message that changing behavior, even temporarily, can have positive outcomes, can reduce the risk of transmission in this community until we can get the resources out there to stop it through vaccination and other interventions.
Yeah, just to follow up on that, doing that harm reduction messaging while avoiding excess stigma. You guys try to thread that needle perfectly. Tell us about those conversations.
We tried to thread that needle perfectly. It's a challenge. I think anytime you have a population that is already heavily stigmatized within a group, anytime you have a marginalized group of people, the potential for stigma is there right at the surface. And so we had to be very careful about trying to balance the need for specific messaging for that population, but also maintaining broader messaging, because we're a federal agency, so we are responsible to everyone in the country. So we needed to sort of find that balance between broad messages for United States citizens about what's happening, who's at risk, but also key messages to really focus on the populations that were most being impacted. And there were some challenges. We got a lot of feedback about it. I think there's always room for improvement in how we do that. But it was definitely a central tenet to the response from early on.
Yeah. Well, thank you for that. So Jeff, you, I think, diagnosed the fourth case of monkeypox in all of New York City?
In New York City, that is correct.
Yes.
So I'll just share my
please.
experience as on the other end of the front lines, which was, yes, I had to look it up today. So on May 28th, I saw a patient of mine who presented with what was sort of atypical lesions around the periorbital area. And, I contacted our local health department because I said, I think this is monkeypox, to which the response was there a prodromal syndrome, which there wasn't? How long was the last possible exposure? I think it might have been 6 days. Nope, that doesn't fit the criteria. Everything was like, nope, it can't be monkeypox. But I'm like, I think it's monkeypox. So I'm like, I'll have you go see a colleague of mine, luckily the same day, who's also who's a dermatologist, who said, I've not seen this before. I think it's monkeypox. And he's like, well, what do we do? And I'm like, I don't know. It says on the New York City Health Department, if you have concerns about monkeypox, contact your local health provider. Well, that's me, but I didn't know what to do. So then I'm like, well, I'm going to call that number that, in New York City, we have 311, which is that sort of information line. And I'm like, they're going to think I'm crazy. But anyway, so I figured out how to get the specimen sent, and then sure enough, on June 1st, so I was looking at that map, so June 1st, I get a call from the health department that said, we're very concerned because the specimen tested repeatedly positive here at our local lab. We're sending it to CDC for confirmation, and sure enough, it was one of the first cases there. And I went home specifically and I looked at the case counts, and I'm like, that's me, because I could see on the next day, well, it's my patient, that was me. But so, throughout this whole thing, I think as a clinician, it was very deja vu, because, we just had COVID, where it was like, do this, not that, do that, not this, I'm not sure what to do. And here we are living this whole thing again, and sort of living in that realm of uncertainty and trying to find answers when there weren't really clear answers was very challenging, to say the least. And I can tell you, as things have improved significantly, but I was also able to get tecovirimat fairly quickly. One of the first practices in New York City to get the early access to tecovirimat, which actually went pretty well for the most part. But again, I had a case where somebody completed their 14 days, did well, and then started having new lesions. And in the current guidance, it said, well, at the guidance at the time, it said 14 days was like the treatment duration. And so then I had to call the health department again, and I think by then they were like, oh yeah, we know you. So I'm like, I have this case and I don't know what to do, and should I extend the tecovirimat? And they're like, yeah, try doing it this way. And so I got some guidance there, but it's been this ongoing thing of trying to figure out what to do. But now it's much better, but that was my experience.
Now, you mentioned one word that's really important here, and I think it's resonated so much from the early days of HIV to the early days of COVID, to the early days of monkeypox, and that's uncertainty. And that how we, as clinicians, oftentimes, at all levels, don't deal well with uncertainty. And, uncertainty about the infection control precautions, uncertainty about the diagnostic procedures. For me, the first case I saw, now no longer do we recommend actually, unroofing the lesion. The CDC just came out with new guidance about not doing that. And yet we were unroofing lesions that were scabbed and, exposing the environment pretty heavily, to virus and doing a lot of things. And so that uncertainty, is something that, and how information flows to people in today's digital age is something that we all sit with. And I just, how do each of you, this is a question for all of you, think that we as, the people dealing immediately with patients and our clinical decision making, how do we appropriately deal with uncertainty? Any ideas or thoughts? I know that's not on the script, but it's just something that just resonates really strongly with me.
I mean, it's funny. So I was on Memorial Day weekend as sort of the CDC clinical person, and I realized we had a lot of information on our website about monkeypox, like from 1990s. I mean, this has not been a challenge in the US for a long time. And I realized that weekend, oh my gosh, our website says that monkeypox is primarily spread through respiratory secretions. People are going to panic because that's COVID, right? And everybody's gonna go, oh my gosh, this is COVID, but way worse. And it was like emergency clearance of website to be like, we need to get this off. So I think, one of the challenges here was like, we sort of had this, monkeypox has been around since the 80s. We actually know a lot about it, unlike COVID that was totally brand new. But what we didn't know was sort of how it applied in this context and what it looked like in an outbreak where, in DRC, it's primarily spread through, like, a big population is 10 to 14-year-old boys who go out hunting small animals and, eat it in the forest and have exposure through animal contact. So in Democratic Republic of Congo, that's a real primary, mode of transmission. So I think one of the challenges too is how do you shift, right? And how do you shift from saying, this is what we know about monkeypox, but this is, this is how it applies. So there has always been a prodrome, until now.
Until now, right.
And some of it is I have just really valued health communicators, and it's really made me recognize the value of them and the value of nurses. I mean, I'm just such a believer that nurses are, our whole job, whether you're at the bedside or whether you're at CDC, is to communicate data into action. That's our whole job, whether it's the patient in front of you or whether it's, national guidance. And I need to keep working on that because it's when you have something complicated, how do you do that in a way that leaves you space so that if you have to change it, you can change it, but also communicates like, okay, I'm a provider, I have a patient, I think it's monkeypox, what the heck do I do? So I don't have a perfect answer, but I think some of it is just working together and partnerships and getting feedback and, being as quick as possible when you realize you have errors and
Yeah, great comment, Stefan.
Yeah, I think, Erin, you hit it on the head. And I think the other thing is to deal with the uncertainty is to just have some level of acceptance of the uncertainty. I think that's something that's really hard, definitely for nurses to do. You don't want to tell your patients, I don't know, or we're not sure, but this is our best strategy right now. And at CDC, we don't want to tell you, this is our best strategy with what we know, but there is some uncertainty. And I think that was a tough lesson for everyone to learn, definitely through COVID, and continuing on through any response. Like Erin mentioned, an outbreak of any disease is going to behave differently than it does sort of, in baseline situations. So I think, acknowledging and accepting that uncertainty and what that means for us as nurses, what that means, at all levels of public health, and then communicating that, like Erin said, to patients and to populations affected, and how to sort of figure out how to balance is really one of the key strategies for dealing with that.
Jeff, you want to add anything?
So, does this go on the record? Okay, so uncertainty. So, I think first and foremost, as a nurse and as a provider, I want to make sure that the person that's sitting in front of me is safe and that I'm taking the best care possible, right? And sometimes I know there are these, strict guidelines and strict rules, but sometimes, I think I'm also an ER nurse by sort of my bringing up, and in the ER, you just you go with your kind of gut instinct sometimes, and you make things work, or you get really creative out of the box to sort of deal with the thing at hand. And so, with this current epidemic, or just what has happened or transpired, I mean, that sort of came into play where I kind of went on sort of what my best guess would be as appropriate things to do, and I just say to the patient that's sitting in front of me, I don't know. We don't know if this will do this or if this is going to happen, but I think this might be beneficial. Are you willing to go down this road with me, or and we have a discussion. So that's kind of how I deal with it. So
yeah, for me, the uncertainty of I had to tell my patient when he came in, and after a very painful unroofing of his lesion, primary pox was on his penis, so it was a painful procedure for him. Now I wouldn't do that, right? So we learned lessons. But number two, because he had such a great CD4 count, virally suppressed for years, didn't know if he would qualify for treatment because were they consider him immunocompromised or not? And so that actually led to one of the things we were discussing about the interpretation of who qualifies and CDC rules versus state rules and how those get interpreted at local jurisdictions. So tell us and describe the relationship between the state and the feds and how that kind of, how those relationships, you guys put out policy but the states in their implementation have choice and autonomy to how they implement that policy. So describe that relationship a little bit more. Don't jump in there too fast.
I mean, I was going to say, it's funny because I feel like, you take like government in 6th grade, and then when I got to CDC, I got a whole new lesson in government. And just realizing, like, for public health in particular, the states are where it's at. And sometimes the counties are where it's at, and the state feels like we do. So I think, I was really thankful that I had experience with Pox, with states before this, because I think that really helped me to understand some of those dynamics. But, healthcare facilities, to local health departments, to state health departments, to then some of the jurisdictional health departments, independent ones like New York City and LA, we all sort of have our roles. And I mean, a lot of it is about building relationships, but CDC basically has no regulatory authority. We can do quarantine stuff that's cross-state. We can do not board lists, but that's about it. And it's really the states that have the jurisdiction in public health. They have the power. And I didn't realize this until I worked at CDC, and I was like, oh, we're kind of supportive. And obviously we have guidelines, but they really are guidelines. They're not necessarily policy. And so a lot of it is just relationships. So like even for me, it was actually really great because I knew a lot of the state vets and the Pox people, as I would call them, or the rabies people, because I had worked there and I had a relationship with them. So I could call up Sally from New York City and we could have a frank conversation about what was happening and how we could support and what the challenges were. So I think, and not everybody does a good job of that when you come in and in any organization and you have to work with partners, really valuing the partners. And so I think we all, can grow in that and being humble in what we can do and supporting the states and what they can do. But it was a real lesson in like, oh, we don't actually have power to do anything. It's all about what the states and sometimes the local jurisdictions are, and just acknowledging that and working from that place and posture.
Now, when I said to Erin and Stefan, I said, the state health department, the city to the state, when I applied for the TPOXX prescription for my patient, punted and said, well, we don't know if the CDC is going to approve this application. Erin comes back and she goes, well, that's actually rubbish because we don't approve or deny the application, it's at the state. But the state's communication was that it was the CDC's decision or not to provide it. And so interestingly enough, as the frontline clinician just trying to provide care for the patient, you didn't know who was on first. And luckily, the patient simply by having HIV qualified and had a great response. But Stefan, what about that communication, from a public health perspective?
Yeah, I think, I don't think this is controversial. So I think one thing that, COVID and these outbreaks have shown us is that our public health system is set up in a very difficult way to address these large-scale events and in general public health. It's not an optimal system when you have 50 different data use agreements, when you have multiple jurisdictions with their own rules about surveillance. We rely on them to give us data. And then we have to make sure that we're using those data in a ethical and correct way, and that we get their input before we just regurgitate it out. And so I think it's really, it's really shed a light on on the public health infrastructure that's been built, in this country. So, but a little aside from my soapbox, I think one of the things that CDC does is we do have a vast sort of communication network with all of our state epidemiologists, state public health leaders. We talk extensively with large organizations that represent those state leaders as well. And it's ongoing communication, weekly, 3 times a week, to make sure that we're hearing what's going on in the states, any challenges that they're having, and then also, getting their input on, things that we're about to release, things that are coming out, making sure that they're aware so that they can give their folks a heads up as well. So it's really that bi-directional communication that's really key to, to working with the states.
It was interesting when we were having one of our planning calls too. It was, I think, a good example of my lesson learned too was between the disjoint, or the non-overlap with the CDC and the local health department. So in New York City, so the dosing interval for the vaccine, I pronounce it Jynneos, is 4 weeks, right? And it says 4 weeks. In New York City, because of the vaccine distribution issue, they were not allowing people to get second doses until it was a minimum of 10 weeks because of vaccine shortage. So in New York City, you could not get one until you had to wait this interval. But then the CDC was saying it's 4 weeks, and so I'm like, well, how come the CDC is saying this, but our New York City isn't allowing us to do this? And so I was like, there is a clear, example of where local jurisdiction sort of rules. But anyway.
And just to say, in some ways that can be more responsive, right? What happens in Georgia is not the same as what happens in Maine, is not the same as what happens in Washington. So I think there are negatives and challenges, but also there's real positives that states have the jurisdictional ability to make decisions that are best for their situation. And I think that really is a strength, and I don't think it would be good for public health authority to reside at a national level, but there's challenges too.
Yeah, Jeff, in your practice at Gotham Medical Group, you have seen some of the highest case counts in New York City, amongst the patients in your practice. Have there been things that surprised you, things that have really stood out about either treatment or vaccine or a response?
Well, I think one of the things, and I don't know if we're going to talk about this later or how this is going to come up, but I'll bring it up now. So I think one of the interesting things, this phenomena of health equity, again, with the vaccine piece. So everybody got, on the day, I learned about vaccine availability the same day my patients did. And you go, and the first people in line to get the vaccines and to fill up those spots, in the first 6 minutes that those appointment slots were available, were white gay men. And, they put the vaccine center in the heart of Chelsea, which is, it's a predominantly gay neighborhood, but it wasn't equitable in all different, it wasn't, access was not fairly distributed. And so just that whole phenomenon of saying like, well, here's a prevention tool, but again, I'm seeing it go right to the population that tends to get everything first. And it was, I think that was surprising again. It shouldn't be a surprise because I'm like, oh, we need to fix this. But it was very clear to me in those first minutes because people who were getting vaccines, I'm like, you got a vaccine? Were typically in that demographic. So
yeah, and we've seen that reflected now in the changing case demographics. With the vaccine equity pilot, I know, Stefan, you've done a lot of work kind of with that, spearheading, some of those efforts. What can you tell us just more about that and tell the audience how they could possibly get involved with that pilot?
Yeah, so CDC, did recognize these challenges early on, and in working with states, trying to develop implementation plans that were equitable and that increased equity for vaccine uptake and distribution. But it was very challenging, and one of the ways that CDC could sort of directly provide vaccine to try to reach, specific populations that weren't being reached, particularly in sort of those early waves of vaccination campaigns, was to develop these vaccine equity pilot programs, which were focused on implementing at the community level for specific populations, Black or African American, Hispanic, Latino, gay, bi, or other men who have sex with men, to really try to focus on those organizations, those local jurisdictions or states that had programs that could really work in that community with trusted messengers, with programs that were serving those communities to apply directly for vaccine allocation so that they could have doses at their disposal for particular events, or if there was a vaccine campaign that they were trying to set up. We know that there was not funding associated with that initially. There is some funding from CDC Foundation. I can talk more about that. If you're interested, come see me. I can provide you with some additional information about that. But in addition to those smaller equity pilots, there were also programs that were focused on larger events that were serving LGBTQ+ populations. So we had a large vaccination campaign at Atlanta Black Gay Pride, I believe at Charlotte Pride, and then at Southern Decadence in Louisiana, to really try, and those were directly supported by CDC and folks from CDC actually going out to assist with those efforts, again, after being invited and asked to assist. So, there have been efforts made, but equity continues to certainly be an issue, and we really encourage communities. We have an equity toolkit now that's available, and we encourage communities to sort of, use some of these resources that they have and then work with their state and local health departments to also kind of move those efforts forward.
In Maryland, I will say that my center applied for and received approval for, I say Jynneos, for Jynneos, potato. And it was quite an easy process, surprisingly. But the health department locally did not say until after we were approved and gone through multiple trainings, when we said, okay, can we use some of our prevention dollars, CDC to the health department to my center, for the consumables, the purchasing of the, all the things we needed to implement. They're like, oh no. No. So, and so we have been approved, gone through the entire process, and so to hear that the CDC Foundation is now offering a grant mechanism that people can apply for. And another interesting thing through these vaccine equity pilots, and I want to make sure this is extraordinarily clear, is that when COVID vaccine got rolled out across the country, there was a huge gatekeeping. And we learned a lot of lessons around that gatekeeping. Who could receive it? How could the health department, what is this chain of receipt and distribution? And for example, even though like my nursing center was being asked to lead and do syringe support programs to integrate COVID vaccine into our syringe support program, I couldn't. I had to engage the School of Medicine because they were the recipient of the vaccine and they would only give it to the School of Medicine. Now with this program, however, we've applied as a School of Nursing and been able to receive vaccine directly. And interestingly enough, once this program has rolled out, they've now asked us, would we like the bivalent booster to come to us directly? So it's having a ripple effect in terms of improving vaccine equity. And I would encourage you to explore how that might be available for you in your local jurisdiction. The mics are available. Oh, thank you, Jim. You read my mind. I was about to call folks to the mics.
There's grass under my feet. I've been here a little bit.
Thank you.
Dr. Whitehouse, so you mentioned there was an outbreak in 2003 in the Midwest. How did you handle that outbreak? Because it didn't make national news. So my question is, if there was an outbreak then, what did or didn't you learn that could have been applied to the current outbreak?
That's a great question. I was in college in that outbreak.
Sorry.
I think one of the fascinating things about that outbreak was there was no human-to-human transmission, which I think is in part, what scares people, right? Whether it's sexual transmission or whether it's intimate, whatever, however it's transmitted.
So it was only among animals. So I think that's in part what made it really different, is it was literally like kids and parents of these prairie dogs. You know, I think I think a good thing that we learned is monkeypox is not that transmissible, which is why, you know, both through vaccination, but also trying to encourage communities to think about their own risk behaviors works. And it's cool because CDC actually did some modeling before, like sort of early on in the response around behavior change and its impact on monkeypox. And then when we saw the impact of some, you know, significant but, you know, harm reduction behaviors, that they actually kind of went along with the trajectory of the model. So, I mean, I think that's an encouraging thing if this is not a COVID. And so I think we did appreciate the transmission. You know, I think it's a good point of like, we need to not only like evaluate, but also like, how does that change what we do going forward? How does this pandemic, well, pandemic pretty much, it's monkeypox, you know, change how we're continuing to respond to emerging infections?
And like with Jeff, in Palm Springs, the hospital system I work for diagnosed the first patient, and they called our local health department, and they said, no, doesn't check all the boxes, and the patient was sent home. This patient advocated for himself for a month, and it took forever to find a lab. Then they got a lab, then it went to the CDC, and you know, when I hear CDC, in my mind, and maybe I'm alone in this, I think the God of public health, okay? You are the words. So in Dr. Whitehouse, you made a comment about how things in Georgia are different than in like Maryland. In my mind, the CDC shouldn't report based on Georgia. The CDC should be reporting for the nation. Georgia has its own public health, do they not? Because like your statement that you made earlier kind of made me think that the CDC is reporting for Georgia instead of reporting for the nation. That was what I heard from your statement. And in my mind, if the CDC is not getting consistent information from the local jurisdictions, because not everyone's on the same system, you know, like not everyone has Epic, unfortunately. But maybe it's time that we get on the same system. How many more millions of people have to die from some other pandemic before we realize communication is a barrier? And you said that's what we do as nurses, we communicate, okay? Let's get on a system. You are the government, okay? Let's get on a system. And unfortunately, sometimes fingers have to be in our local governments to save lives. Just like you made the mask mandates, we did it, right? Those are fingers didn't people want, but how many lives were saved? Maybe your fingers need to be in to get a consistent communication system. Because where I live, you know, STI goes to this person, and then they have to go to this person. And by that time, that person slept with 20 different people. I'm a gay man, hello. It's what I do, right? So it's what we do. Sorry to say that, but it's what happens in our community, right? You have places of sexual contact. What was that word there, Stefan, that you used? Sex on premises, right? So I hear excuses from government agencies where I turn on my TV and it's the public information officer or the secretary giving me information. It's politicized instead of you, the nurse practitioner, or the physician on the TV telling the public as the licensed professional with the training what we should or should not be doing. Not the elected official who doesn't know anything because they're politicizing it. And I am on a soapbox because I have lost too many friends to too many illnesses because it was politicized. And then you also made a comment about people who have anonymous sex. A lot of the apps have the ability for that person to notify their partner that they are at risk or have been exposed. Grindr has that. You know, I can ask my patients, you know, do you know the person you slept with last night? I don't know their name, but I know their screen name. Well, let's open the app right now and let's let them know. We just have to be comfortable with talking about sex with our patients right then and there and not making it taboo. Use the street terms if you have to, all right? It's not about our comfort, it is about the comfort of our patients.
Great. Thank you, Jim.
Can I respond really quick?
Yes, Stefan, respond.
I just want to respond really quick because I think Jim, what you said is really powerful, and thank you for saying it. And I will tell you that I think it's okay to say that many of your colleagues at CDC agree with you 100% about the need for change, particularly about the need for structural change, all the way from the local health department up to the federal government. And I'll tell you that, you know, there are a lot of, well, there's an entire internal program right now that is looking at that. I mean, Dr. Walensky has said this publicly. She said this in front of Congress. She said this to the Times, that, you know, that she is actively looking at how to restructure so that responses get better and better every time, and that this doesn't continue to happen. So, you know, CDC is undergoing a change. We've, you know, I mean, I've only been there for 4 years, but I've been there for some 4 significant years. And you know, and we, you know, we understand, because I was the same way. And you know, when I was a nurse practitioner, I was like, what is, you know, whatever CDC says, they must be. But it's, you know, every organization needs to be evaluated and needs to look at their processes, and that's definitely occurring right now.
Absolutely. And the CDC has brought in a nurse, Mary Wakefield, Dr.
Yes,
Mary Wakefield,
Dr. Wakefield,
to actually evaluate exactly those processes that you're talking about. Yes, Dr. Voss, I think
one of the big black holes is the national stockpile. Can you talk a little bit about who controls the national stockpile? Because CDC got really attacked by especially West African countries for not releasing vaccines to West Africa when all of Europe and America was vaccinated in a hurry. Can you talk a little bit about the national stockpile and who does this? Is there actually a physical place where this is all hoarded?
Yeah, there are actually physical warehouses. I'm best friends with Leonard. We talked every day. You know, I mean, I think this points to one of the questions we didn't get to about global equity. You know, I mean, so the Strategic National Stockpile is under ASPR. It used to be under the CDC, and then it was moved to the, what is it, Assistant Secretary for Preparedness and Response. You know, I think that this point, like, global health equity is also a really important piece, and it's very challenging, and it reminds me of what Dr. Field said yesterday about the pie. Because I think we often think about global health as a pie, and that if the US gives more of our pie piece away, that somebody's gonna miss out here. And I think we need to think about having more pies. Because it is true, you know, CDC was doing a vaccine study in DRC among healthcare workers that was finishing kind of when this started. And there is a lot of vaccine inequity. We saw that for COVID. You know, we saw that in the US, we keep our vaccine in part, and that was one of the challenges even. I was very instrumental in the beginning vaccine distribution. It was really difficult to figure out how much vaccine do we give away and how much do we keep for our own preparedness. And those are not easy questions, but I think again, it's reimagining the perspective around public health and being willing to think about more pies. But I don't have easy answers. I will just tell you that I love those people at the National Stockpile, and they work their butts off. So, you know, then that's one of the challenges too, is like even at CDC, seeing how hard people work and then seeing how it's not always reflected in the media or in what happens at higher levels of government. But I think it really points to global inequities that we need to really think about as we talk about public health.
Okay, Dr. Guillermo Ramos.
Hey, Vincent Ramos from Duke University. So I have a quick comment and then a question. So the comment is, I want to pick up with what Dr. Farley was saying. It's really great to see 2 nurses at the CDC, and I think it's important to acknowledge that yes, we can do better, but we're very appreciative and thankful. So thank you very much for all that you're doing. And so it's really amazing. So Erin, my question's for you or for anybody on the panel. So I'm curious about the efficacy of a single dose or differences in cases for people who are not vaccinated at all with Jynneos versus 1 dose. And do I have up to 2 years to get that second dose in cases where people are refusing that dose? Because the part that I'm kind of struggling with. Thank you.
Yeah, thanks. And let me just put in a little plug. I am also president of the CDC Nurses Work Group, and I am always working to recruit more nurses to CDC. And so if you are at a school of nursing and you want me to come talk about nursing at CDC, you just email me, because I am on a rampage. I'm meeting with Mary Wakefield in 2 weeks to talk about CNOs and let's get more nurses at the leadership table. So that's my little plug back. So we're trying. I don't know that vaccine effectiveness data is available, but there are lots of people that are working on it. I would say, we know that the vaccine is more effective after the second dose at this point. So, whether that second dose, we don't, whether that second, it's sort of like any time afterwards is great. Obviously, they're going to be maximally protected when they have that 28 days. But in general, when you think about vaccine guidance, even if it's 6 months down the road, it's still probably beneficial to them. So I would say go for it, even if it's 2 years. And I think that data's coming. What we saw from that MMWR is that 1 dose does help. 2 doses is going to be better. But at this point, based on the information that we have. But yeah, at any point, I would still encourage them. And we also don't know about how long that immunity lasts. Smallpox vaccination in general was lifelong, but in that 2003 outbreak, there were people who had been vaccinated for smallpox as a child and got monkeypox. We also don't know about severity around vaccination and how much vaccination reduces severity. You would anticipate that it would, but we don't have data on that yet.
And also, I would say that the initial rollout, because it was only used as post-exposure prophylaxis, we saw multiple cases between dose 1 and dose 2. So when we use it more as prevention as opposed to post-exposure prophylaxis, we might see that number of 14 times reduction after 1 dose, even go higher.
Mm-hmm.
That's a potential as well.
Mm-hmm.
Okay, great. Carol, I think, yeah.
Thank you for a great presentation. That's wonderful, and thank you for being so flexible in the timing of this. First a comment and then a question. My first comment is about when you were talking about uncertainty, and I was thinking about how that is us being truthful to our patients about uncertainty, yet how that's heard often as they don't know what they're talking about. And how do we balance that, right? I have a sister who has a chronic illness, and that's all she ever talks about is they don't know what they're talking about because they told me they don't really know. So that's a delicate balance, and I think maybe one time we should have a whole session on that, right? But my question is around, so I was having a conversation with someone at CDC around how the cases have fallen off because of the combination of behavior change and vaccines, right? And that behavior change is probably not going to be continued, right? That there's going to be an uptick or a reversion back to old behaviors. So how do we continue to have interest in vaccines when it seems to have now fallen off the radar? You don't hear about it any longer. Is it really falling away? But so is interest in vaccines starting to fall away as behavior change now recedes as well? So if you could comment on that a little bit.
I'm not a clinician. I think it goes back to comprehensive care, and I would speak to Dr. Farley. I think we need to integrate monkeypox vaccine into prevention along with HIV and STIs, but I defer. I'm looking at Jeff and Jason as the clinicians.
I thought it was a CDC question, but I will say, I think the one thing that we can say is this is not new, right? This has been around. The first case, 1970. So this is a 50-plus year condition. And so when we're thinking about prevention and we're thinking about things, yes, this may be the quiet before the storm, but we have not fully eradicated this condition here. And so we should still consider, seize the time when there is a calm to really be proactive and focus on prevention. So I think we need to integrate sort of that messaging a little bit.
And I was just going to say, I think too that this is something that is not happening in isolation of other social determinants of health, and in marginalized groups. And I think we have to keep this idea of, it's been mentioned here so much, and I love that, this syndemic approach to how we look at these types of outbreaks, because even if there's a low level of transmission, certain populations are going to remain at risk, and so we have to keep that in front of our minds whenever we're working with these groups to make sure that we're treating the whole person holistically and we're keeping all of these things front and center to their care and really incorporating this syndemic approach for HIV testing, STI screening, vaccination, everything that's going to keep them healthy.
I think also alternative dosing strategies and locations are going to be a big important thing to hype up in the community. Obviously, original forearm-based dosing led to scarring and or discoloration that could cause, I think Justin called it a stigmata of monkeypox, and it causes stigma. And so now that we have alternative dosing sites, subscapular, behind the deltoid, and can think about both a sub-Q or an intradermal for populations that may be more at risk for keloid formation, that gives us a lot of things that we should be messaging to the population, because I think a lot of hesitancy came from, trying to also avoid scarring for some people.
And I know we're way over time, but just a sort of a similar model that I'm just thinking of is like with meningitis vaccine, right? So we recommend meningitis vaccines for MSM, high risk for acquisition of meningitis, but we don't see a lot of meningitis, right? But we still offer it as part of preventive care, and at least I do for my PrEP patients. And so it's one of those things where it just becomes a part of your routine care, I think, is how it should potentially roll out in the future.
Unless they're traveling to Florida, and then they all need to get it, because that's where our outbreaks were, actually. No, I'm serious. Every time I talk pre-summer for my PrEP patients, I'm like, okay, where are we going this summer? What we doing? Let's talk about that. What kind of play are we going to have? And really thinking about true people being sexual beings in their fullest extent. And so I had one group, a physician and his boyfriend, who were getting ready to go to Spain right in the heart of the outbreak. And we had a long conversation about whether or not they needed monkeypox or not. And you could tell that neither one of them wanted to say that there might be additional partners when they got to Spain. But we eventually came to that point. They're like, yeah, probably so. And I'm like, great, let's get you a monkeypox vaccine. Like, that's really critical and important. So I think expanding it into our armamentarium of sexual health is a great solution. Yes?
Thank you all so much. I'm a huge fan of the CDC. I also believe that y'all are God of everything. And it's a quick story. So I'm an old school public health nurse for over 30 years, and I held on to the idea of calling STDs STDs. I said, I'm not gonna stop saying that until the CDC changes the STD treatment guidelines. And sure enough, last year, y'all did it. So now I had to move to STI. But a couple things, I do work for the Virginia Department of Health, and as far as the 2003 outbreak, it was a perfect example of how public health should work. Those cases met the case definition for monkeypox, so they were quickly able to identify what it was. And then through contact tracing, they were able to go back and figure out that the prairie dogs had been housed in a place where there had been African small mammals that had been imported. And so since then, the CDC has banned importation of those African small mammals. So that was quickly nipped in the bud. And you're right, it didn't make a big flash in the news because it didn't affect that many people. But that's how public health is supposed to work, where you don't hear a lot about what we're doing. So what you've been hearing now with COVID and monkeypox is we don't know what the frick we're doing. And I can tell you part of it is, as far as why we don't do more than what we do, we have no staffing, we have no salary, we have been chronically underfunded forever. And for the most part, we have pretty much existed in the back, not the backwoods, but it feels like the backwoods. And those of us that are left are the ones that are really passionate about what we do, and we're really struggling. We're not getting a lot of new young nurses coming into public health, and those that hung on during COVID are finally now going to retire. So we're going to have another wave of people that we don't have. Bringing it back to monkeypox, I'm really struggling with our leadership as far as, we're not hearing a lot about it anymore. We are not getting any media inquiries, and so everything has kind of calmed down. But I really want to get targeted for the people that are at most at risk of severe consequences. So really working hard on those people that are data to care, people that are lost to care, people that don't know they have HIV. And so not stopping. And then I so appreciated, I attended some webinar where they had nurse practitioners that were offering HIV and STI testing when anybody showed up for monkeypox, and that they were offering PrEP. So just taking that opportunity to do more and just doing what we do well. And but with that, I didn't really have a question, but if you have any ideas of how to target those people, our PR people said we have no money, so there's no way to advertise, but any ideas y'all have, we really appreciate it. And thanks for everything y'all do.
Very nicely said. Very nicely said. Anyone want to? Yep, she's telling me. We've got 3 people at the mic, so let's get through these last 3 questions really quick. Yes.
Hi, my name is Daniela. I'm a nurse at a Ryan White clinic in public health department, and I just wanted to say that I really appreciated the patient-facing printouts that were available from the CDC. Just right away, their focus on harm reduction instead of abstinence or fear, just all the messaging and the way that it did walk that tightrope, that fine line between serving the communities most at risk while doing their best to avoid stigma was really important. Those printouts were really valuable to me, being able to share them with my patients and get good information out into the community. Yeah, I just wanted to say thank you. And you guys, I think we all work together to do a great job to, you know, keep it from getting worse.
Thank you. Great. Sheila.
Hi, everyone. For those who I haven't had the opportunity to meet, I am ANAC's new Director of Education Programs. So it's been really wonderful being here and, of course, the talk today. But I wanted to just take the opportunity to give you a little bit of a spoiler alert that we are having another in our series of monkeypox webinars. It's scheduled for Monday, December 5th. It will be focused simply on So it will be focused on vaccines, the science and efficacy, readiness, hesitancy, and equity and access. So Dr. Farley, Dr. Orlando Harris, I don't know if he's in the room, will be speaking along with Daniel Driffin from the HIV Vaccine Prevention Trials Network. And for those who may not have had the opportunity, we have a series of other sort of monkeypox email blasts and some webinars on our website, so please take a look. And if you're not signed up for our email, please do that, because that's where you'll find out more information in the next couple of weeks about that next webinar. So thank you.
Thanks, Sheila.
Thanks for that, Sheila. And I just want to thank the panel. I really appreciate all the comprehensive information. I had some very practical questions, and maybe they're already on the CDC website. My name is Myra Rutland. I work at FQHC in Philadelphia. And, you know, when monkeypox happened, my colleagues looked to me to say, hey, what do we do? And I'm like, oh, you know, I'm like, give me a couple of hours and let me look it up. And, you know, I love the CDC website. I do believe it is the go-to. You know, I use other sites as well, but I rely on the Centers for Disease Control. But what I have a grudge with monkeypox is I felt it would have been good to have a very clear one-pager for the stuff that PCP primary care providers need. What do the images look like? Because they're not the typical ones that we saw in the 1970s. Do you vaccinate someone who happened to get monkeypox in between the first and second dose? If so, when? How do you swab for monkeypox? You know, it is a dry medium. I know that because I had to dig around and find it. And I've been on Zoom calls ad nauseum to get all this information, but I don't know that it needs to be that hard. You know, it would be nice to have one place with all that information just lined out. This is the type of swab you use. This is how you obtain it. I love the pictures here with, yes, the subscapular intradermal injections and the various sites, but, you know, and maybe what I'm asking for is unfair because, you know, maybe we're playing Monday morning quarterback, but I think that it would be nice to have that going forward. I really appreciate all of you and the hard work you do. Go nurses, woo!
Yeah, one of the things I think is from CDC perspective, just to address that, is keeping up with the information and getting the information available not only to the public but to clinicians in a rapid amount of time, and with information constantly changing about the ways we diagnose it, where are the lab capabilities, what it's not, all of that. And so the one thing that I would say is that there is an email listserv that comes out weekly, if you don't know about it, from the CDC as part of the COCC, the COCA or COCA.
Yeah,
Do you want to tell us about that?
Yeah, so CDC has a COCA service, which is Clinician Outreach something, and COCA. And,
the COCA?
So if you have interest, it's a listserv that you can sign up for. It will give you email blasts for any type of update. I think health alerts will also come through COCA. We also do COCA calls where we do like real-time webinars and even answer real-time questions. We also have a monkeypox partnership email that comes out once a week that we list all of the resources that are available. We also have a partner call instructions that we host weekly nationally for anyone who wants to participate. And we also answer real-time questions there. So if you all have interest in any of that, you can just let me know after, and I can give you the information on how to sign up for all of those services. They're all readily available through CDC.
Thank you so much, guys. Give the panelists another round of applause.
Thank you.